Hello, and welcome back to the Med Madness podcast, your trusted source for everything USMLE. Today, we're diving into a critical topic for all those preparing for the USMLE Step 2, the prophylactic administration of anti-D immunoglobulin in RHD negative patients. Understanding this topic is crucial for ensuring the health and safety of both mothers and their future children. Let's get started. The rhesus or Rh blood group consists of 5 antigens, with the D antigen being the most significant in the context of fetal and neonatal health. When an RHD negative woman carries an RHD positive fetus, there's a risk of alloimmunization, also known as sensitization. This occurs when fetal erythrocytes enter the mother's bloodstream, leading to the production of antibodies against the D antigen. While this immune response doesn't typically affect the first pregnancy, it can have devastating effects on subsequent pregnancies, causing conditions like hemolytic disease of the newborn or hydrops fetalis. To prevent these complications, anti-D immunoglobulin plays a vital role. It works by binding to the D antigens on any fetal erythrocytes that enter the maternal circulation, thereby preventing the mother's immune system from developing anti-D antibodies. Routine prophylaxis is crucial. We administer anti-D immunoglobulin universally at 28 weeks of gestation and again within 72 hours after the delivery of an RHD positive infant. But these are not the only times when administration is necessary. There are specific situations where RHD negative women should receive anti-D immunoglobulin to prevent sensitization. These include within 72 hours after a spontaneous abortion, an ectopic pregnancy, a threatened abortion, or a hydatidiform mole. Procedures like chorionic villus sampling and amniocentesis, as well as events such as abdominal trauma, bleeding in the 2nd or 3rd trimester, and external cephalic version also warrant prophylactic administration. At the first prenatal visit, it's standard practice to test for blood type, RHD status, and the presence of any red blood cell antibodies using an antibody screen or indirect Coombs test. This initial screen is crucial, especially for multiparous women who have a higher likelihood of having been previously exposed to RHD positive blood. If the antibody screen is negative, indicating no alloimmunization, the next step is administering anti-D immunoglobulin at 28 weeks of gestation. This timing is important because the immunoglobulin persists for about 12 weeks, covering the critical period through the 3rd trimester. Before administering anti-D immunoglobulin, a repeat antibody screen is essential. This ensures that no spontaneous alloimmunization has occurred since the initial screen, as anti-D immunoglobulin is ineffective in women who have already developed antibodies. The risks associated with not administering anti-D immunoglobulin are significant. Alloimmunization can lead to severe complications in future pregnancies, including the destruction of fetal erythrocytes by maternal antibodies, leading to conditions like hydrops fetalis. On the other hand, the administration of anti-D immunoglobulin is relatively safe and has minimal risk, making it a critical intervention for all RHD negative women who have not been previously sensitized. To illustrate the importance of this intervention, let's discuss a real-life case. Imagine a young RHD negative woman, Sarah, who is pregnant for the 2nd time. During her first pregnancy, she did not receive anti-D immunoglobulin because the significance of this preventive measure was overlooked. Unfortunately, she became sensitized to RHD positive blood. In her 2nd pregnancy, despite being healthy, her baby developed severe hemolytic disease of the newborn, leading to hydrops fetalis and requiring intensive medical intervention. This situation could have been avoided with proper administration of anti-D immunoglobulin during her first pregnancy and after any sensitizing events. Sarah's case underscores the vital importance of routine screening and timely administration of anti-D immunoglobulin. It's a simple yet profoundly impactful measure that safeguards the health of both mother and baby, preventing severe complications in future pregnancies. In summary, the administration of anti-D immunoglobulin is a cornerstone of prenatal care for RHD negative women. It effectively prevents alloimmunization, ensuring the well-being of both current and future pregnancies. As healthcare providers and students preparing for the USMLE Step 2, Understanding the protocols and importance of this intervention is essential. Thank you for tuning in to today's episode of the Med Madness podcast. Stay tuned for more in-depth discussions on critical topics that will aid you in your medical journey. Remember, knowledge is the key to better healthcare outcomes. Until next time, keep learning and stay curious.